some general rules before we get into the dementia part for prescribing to this age group, which is usually an older age group. Is there a clicker to change slides?
I don't.
Okay. So some of the general rules, one of them is start low at low doses and go slow with increasing those doses. So as we get older, our brain mass shrinks, so we have more side effects. Our lean mass, our muscle mass, goes down, and our metabolism goes down, so we slow down our clearance and absorption. And we're always on an increased number of medications, and that can lead to an increased number of side effects. So there is a list. This is a very abbreviated one. This is called the Beers list. The regular one's 45 pages, is that?
Yeah, the updated one is 45 pages.
But these are medicines that have frequent side effects. You don't have to memorize it, just there are side effects to medicines, and the side effects get stronger as we age or if we're very, very young. So that's the point there. The most frequent one we see are the anticholinergics, and Benadryl or diphenhydramine is the over-the-counter one that we all have in our closets. This has the most frequent side effects, and there's some sayings. Blind as a bat, your eyes dry out. Dry as a bone, your sweat, your saliva, your eyes. Mad as a hatter, people get agitated, they hallucinate, they get delusions, they get pretty violent sometimes. Red as a beet, your skin turns red. Hot as a hare, it's hot. And full as a flask, sometimes you're not able to urinate, and that can cause some very, very, very agitated times until you can get a catheter. And so what can the physician do for dementia? And so sometimes it can be frustrating, and the physician might say, not much, because we're not able to cure it. We're researching, but we can't do it now. This is a long journey, and there are little issues and little symptoms that come up that can be moderated, and that can make it easier for y'all, it can make it easier for everybody. And then what we'll do is we'll use some of the side effects of other medicines that aren't necessarily dementia medicines that can maybe help with some of these symptoms. So it's not full clearance, but we can try to make it more tolerable, if that makes sense. And so, still with the general rules, it's going to be trial and error. We don't have we want to go for one specific symptom at a time. There's no blanket treatments for, quote, behavior issues. Instead, we want specifics. So one specific could be, you cannot sit still and paces all the time. Another one is, he sleeps all day, he's up all night. Another one is, he's punching holes in the walls. Those kinds of things. The more specific we are, the more targeted we can be. So we want to use one medicine at a time. If that doesn't work, we want to wean it. We don't want to have a long list of medicines. If it works partially, then we can have a discussion. Do we need to try a new one, or do we add on to help the one that's working a little bit? Everybody's kind of different, so different medicines work for different people. A lot of these symptoms, and what you'll see a lot is dementia is kind of like going backwards through childhood. So it's a phase is something that we use with our young people, the 2-year-olds and stuff like that. So it's a long journey. There's going to be a few bumps going down, kind of like we had raising our kids. We'll tackle one bump, then there'll be a breather, and then another bump will come down the road. Oh, sorry, let me go back.
Let me check.
Huh?
I got it.
Okay, because I don't know how to go.
So that's true, true.
All right, so here's just a list of some of the other non-memory issues that can come along. Your personality can change. You can become more quiet, more bragging, agitated. Sometimes apathy, which is just no emotions at all, can happen. Depression can occur. Anxiety, delusions, hallucination. We'll go into all these in more detail, but here's just a list of the non-cognitive issues. All right. So the big ones that we're going to spend most of our time on are the 3 Ds. We have delirium, I'll define that, depression, and dementia. And so here's what dementia looks like. This is the line for Alzheimer's. So it can go 10 or 13 years. It starts normal and there's a plateau of just some mild memory problems. And then the roller coaster goes downhill and you have some behaviors in there, and then it flattens out again when it's severe and ultimately death. So it is a fatal illness. So here at the beginning, we're going to diagnose dementia. It can't be done like it's a flu test where we draw blood and say, yes, you have Alzheimer's disease. One memory test is not sufficient. I was memory tested after the reason I retired. I scored an 80 on the IQ test, and they said, you're normal. That's not where I started. And so you want to have a starting point, and then if the memory's going down from there, then we can diagnose it. So you can't draw a line with just one dot. You need at least 2 dots to see if there's memory's getting better, worse, staying the same. So we would need a couple of memory tests. A careful history must be done, and not with just the client, but also the person who brought the client to you. They might be a little bit more honest in the clinic setting. And then we want to rule out the reversible causes of memory loss. There are many of those, and there's a little mnemonic for it. It's dark, I watch death. So infections can do it. The most popular one is the urinary tract infection, but other ones can do it, like pneumonias. The next 3 are usually drug and alcohol problems, either being drunk on it or withdrawing from it. Then you can have brain pathology, strokes, tumors, seizures. Strokes do get better most of the time. Infections. Poor oxygen, the hypoxia can happen. Deficiencies, you don't have enough thiamine, that can happen with alcohol or not eating the right things, or certain GI problems. B12 deficiencies can cause memory problems. Thyroid problems, diabetes, blood flow problems, trauma, heavy metals. These are all treatable, so we want to rule these out. We don't want to send you home with one of these that can be treated and your life be over. And so, so what we'll do is we're going to first take a look at your list of medicines. Do you have any side effects from the Beers list before? We're going to get labs and images to rule out that I watch death mnemonic. Complete blood count, metabolic panel, check for ammonia levels, liver functions, inflammation, thyroid problems. We'll get a CT of the brain or an MRI of the brain, chest x-ray for pneumonia, check your oxygen. The CTs and the MRIs, we cannot see Alzheimer's on that. It's kind of like the memory test. We need a series of them. If your brain's shrinking in certain places, that can tell us Alzheimer's, but we all have different brains, so one image ain't gonna do it. And if we have any problems deciding, sometimes an EEG can be used. It'll be slower with dementia, but it can also show seizures and other things that can point us in the right direction. Once we do all these things, we're over 90% accurate that this is dementia, usually Alzheimer's. So the first D is delirium. It has other names: ICU psychosis, encephalopathy, organic syndrome, a bunch of words with cognitive in it. What it is it's a change in consciousness. Consciousness is how awake are you. And so what you'll see is people falling asleep and waking back up mid-sentence. So it waxes and wanes. It comes and goes, and that can be 30 minutes of confusion and then back to clarity, and it just kind of happens that way. At this age, we don't get fevers anymore. We get deliriums. And so it means that there's something medical going on. And what gives us that clue is it's a rapid onset, kind of like a fever would be. But our bodies don't make the temperature go high, they just make us confused. And so you can have a change in mood, you can have a change in cognition, and so on these tests, like the mini-mental status exam, if you have dementia, you'll probably get like a 23 or 21 on it. If you have delirium, you'll get a 2, you know, and you'll tell me to go somewhere. They also get hallucinations and delusions. That's probably what we see the most of. And then irritability, agitation, or they just don't move at all and they lay in their bed. And so the hallucinations are usually visual, and many of the consultations that we get in psychiatry are to help with this. And so they are treatable. The first thing we want to do is safety. So we want to protect the caregiver, we want to protect the patient, we want to protect the nursing staff if they're in a hospital or ICU. So we will do that usually with antipsychotics. We just want to settle them down. These are just temporary things to stop the hitting, scratching. We want to make sure that it's light in the daytime. Open the blinds in the medical room, in the room that they're in. So we want light during the day, and we want dark at night. That's what our brains want. And we want them to sleep at night. That's the most important thing, is sleeping. And so the other thing is we want to find the cause of the delirium, one of those I watch death things, and we want to treat it. This is an emergency. If we don't treat it, they will die because it's an infection. And so the next D is depression. And so new onset depression is common in the geriatric population, and it can cause cognitive problems. Sometimes it's hard to get people to get it treated because there is a stigma that comes with it, especially in the generation that we're discussing. But if it's phrased as a medical condition, which it usually is, from the aging, like you're not getting enough blood to the brain, things have slowed down, your car has 150,000 miles on it, and things kind of slow down a little bit, that's usually something that they'll agree with, that they're not weak, they're old. And so personalities don't change unless there's a medical reason. So when we're 25, around that age, we kind of turn to adults, our personality gets set in stone, and it should stay there until we're in our 90s, 100s, or death. If your personality changes, that's a clue. That's something that's going on. If they're still able to communicate, they'll say they're sad. If they're not, if they're farther in dementia, they're not able to communicate, then you can still see the tearfulness, the rubbing, the anxiety that come along with it. And so irritability is depression until proven otherwise, especially with men. They get more irritable and they get tearful. This has SIGI CAPS, which is in all the textbooks. So sleep will change, it's usually less sleep. They lose interest in their hobbies, they feel guilty for no reason, their energy goes down, their memory goes down, their appetite goes down. They either don't move at all or they get very agitated with a very short fuse, and they'll mention things, not necessarily that they plan on doing it, but I wish I were dead kind of phrases. Some of the medicines that we use for this, I didn't list all of them, but the safest and most common ones are these SSRIs and SNRIs. They stand for serotonin reuptake inhibitors. Prozac, Paxil, Zoloft, Lexin, Lexapro, Effexor, Cymbalta. If they're not on one already, I like to avoid Prozac because it's a very long-acting medicine, and if we're not clearing medicines as fast as we used to, it may build up in the system. Paxil has some of the anticholinergic effects like Benadryl does, so that can add to some of the confusion. But we don't use the old ones down at the bottom, the tricyclic antidepressants or MAOI inhibitors. They're just not safe unless you're watching real close. Another one on the list that didn't make it is Wellbutrin. It can help with depression, but not so much with anxiety. And Ritalin is actually kind of a quick pick-me-up if they're just not functioning at all. Yes, ma'am.
Paroxetine, I read an article about it that said that about its half-life. Can you explain that to me a little clearer?
The half-life is how long a medicine stays in your system.
Right.
So half-life would be half that time. And so Paxil is one of the shorter acting ones. and so it's cleared quicker. What that means, Effexor's another one like that. What it means is if you miss a dose, you notice it the next day. You have some withdrawal.
Okay, what about long-term with it affecting hallucinations and problems? Because my wife was on paroxetine for 3.5 years, from the time she had a stroke until just 6 months ago. Her hallucinations went up tremendously. I mean, we're talking 500%. Everything she saw, including the alarm system in our house, which has 4 lights on it, those were people looking at her. And I mean, it was that type of thing. She wasn't sleeping, she was walking around at night. I was up 24 hours a day some days, just following her around so she wouldn't fall or have a problem. And we took her off of the paroxetine with the advice of my doctor and also neurologist. And we, instead of giving her another SSRI, we wound up giving her a homeopathic product made with it had chamomile in it, lavender, L-theanine, lemon balm, and another additive to it, and then taking it in a capsule with all, and she began to sleep almost within days. Just would go to sleep and sleep 8 hours, 7 hours without hallucinations as bad. And that's been now close to 90 days. And I've seen some remarkable change in that part of it, but the irritability and some other things are about the same. They really didn't go down a whole lot. She's very subject to UTIs. We go through that about every quarter, at least one time, sometimes twice. And so what are options for those? Do you have a...
Well, like I said, the paroxetine, it may have worsened the hallucinations because it acts a little bit like Benadryl. It has an anticholinergic property to it. Everybody's an individual. What you just did right there is you gave me a very great history for your wife. She can't tolerate these kinds of things that make her hallucinate more, that make her worse. And so that would help us, that would help guide us, but everybody's gonna have different reactions. But keeping track of when the medicine was started, when the symptoms started, is a very good thing to do for your doctor. Any medicine, and we can't predict what's going to do it, what's not going to do it, and so that's the trial and error part. But to keep track of it and not start 3 medicines at once, because then you got to guess which one did it, you know. And so doing them one at a time, keeping track of when things start and where their med changes when it did, is a very good idea. And so that was a very good illustration of it. For the irritability and anger, maybe Paxil wasn't the right choice in trying another one of these, but I would try it at a very low dose and go from there. These medicines take a few weeks to work. And where I trained, their favorite ones were Zoloft and Effexor, but everybody reacts differently to different ones, and so that would be an idea. But it's going to be stopping, don't keep it and add to it, just stop it and start another one if the same problems are happening.
What is the flush? I call it the flush, where you reach, where that's gone to zero, that amount of, say that amount of Paxil or paroxetine, and when it gets to zero, and is that at the point you make the change, or before you get to that point?
What I did, because there is withdrawal and then also the depression can return, and Paxil's not an easy one to stop, you want to wean these.
Well,
and so I would cut it in half for a week, cut it in half for another week. But in the meantime, while that one's going down, maybe start another one to take its place. So for a few weeks, they may be on 2 medicines, but since they take a few weeks to work, you don't want to have those couple of months of depression, you know, and so replacing it that way might be an idea, but I wouldn't start one and stop one at the same time.
Okay.
Or just stop one and add one, because the withdrawal can be quite a problem. And in the future we can get farther into these 3Ds. We're just kind of brushing over them right now, but that's a very good question. So the depression at this age, if they haven't been depressed their whole lives, usually is a medical issue, kind of like what we were talking about, like your car has 150,000 miles on it and it starts squeaking a little bit. Same thing with our bodies. These medicines are very safe usually. They can actually extend people's lives and keep the brain from shrinking as fast. And if it works for depression, this is a forever treatment. This is not one that we wean in the later stages because the depression will return. Maybe we won't know it because they can't communicate to us. And they're safe, so it's not one that we need to get rid of. Anxiety can sometimes accompany depression, or it can be alone. It occurs very rarely, like heights, and you're not going to be around heights much. You can use these as needed medicines, these little yellow pills that the Rolling Stones sing about. Ativan sometimes though can have the opposite reaction. It can make people get very agitated. That can happen. We don't know. We don't understand exactly why. But if it's a constant anxiety, then we'll use something more safe and mild, like Buspar or one of these SSRIs or something like that, because they don't make you feel drunk like those other medicines do that we would just use just
Quick question.
Yes, sir.
What's your opinion on CBD gummies, things like that?
They are prescribed for these situations. They can help with anxiety. They can help with appetite. They can help settle people down. They can help people sleep. And so my opinion of them is I agree with that. There is a stigma to it, but there's different qualities to them. Some of them that are used to catch a buzz are not what we use in the medical field. That can help calm the body or relax people, and that would be more of the CBD part or the.
Who do you go to properly prescribe those? Because most doctors, MDs in the practice just don't prescribe that, or their contract with their employers, the hospitals, they won't allow them to.
Right. And another good thing is that they're safe. They're not going to give a Parkinson's disease like some of the medicines we use do. The clinic on Line Avenue, close to here, that kind of mirrored looking building, they have a doctor there that can prescribe it to you if you have one of those issues on the list of medical problems that could require it. So there is an MD there that can prescribe it for you, and then you would take that prescription to the Hope Pharmacy across from LSU Med Center, and they would fill it for you. And there's different ways to do it. There's gummy bears, there's drops you can put under your tongue. Some people smoke it. So there's different ways of doing it. But yes, if you want to go to that clinic, they'll see you and they'll prescribe it.
Not to take away from your time, are those fast acting? You see results within hours or days, or does it take months, weeks or months to see an improvement?
Sometimes 2 hours if you're eating it like a gummy bear, but you'll either see the calming effect that day or the next day. So 1 or 2 doses, you'll be able to tell if it works or not.
Okay, thank you.
Okay.
Excuse me, would that cause a fall? Doctor told me not to give it to my husband because it may cause him to fall.
The medicines I said before, the Xanaxes and Valiums, those cause falls. And some of them,
But these,
they don't affect your balance. The other anxiety medicines feel like alcohol. They work on the same part of the brain as alcohol.
Sir, what is your opinion on long-term use of Exelon patch?
Well, we're going to get to that when we start talking about the third D, dementia, and I will answer that exact question while we're doing it. This is just a little chart to compare the 3Ds. Delirium comes on acutely within hours. Depression is recognized in weeks or months. personality change kind of thing. Dementia comes on very slowly and consistently over months and years. The person complaining in the office for delirium varies, usually the family or the nursing staff. Depression, the patient says I'm sad, and dementia, the family notices it, not the person with the dementia. And consciousness, how awake are they? Delirium, very clouded. Depression, they're clear but slow. And dementia, they're usually perfectly clear, just with poor memory. All right, so now we're to the dementia medicines. And so what we want to do after the diagnosis is made by ruling all those things out is we want to start early. We want to start early. These are not cures. By the time we get to the diagnosis, many brain cells have died, and those aren't going to come back. And so what we want to do is we just want to slow down the decline, that S curve that I've showed you. We usually see improvements within a few months, and they may last. They may stay steady for 6 to 24 months. These don't always just help memory. Sometimes these annoying things, apathy, attentiveness, conversational language can be improved with these. After 1 or 2 years of being on these medicines, this may answer your question, the decline will start again. We'll start seeing the decline again. However, if you take them off the Exelon patch and they're not having side effects or anything like that, that decline will become more rapid. And so if you take the patch off, they'll go down faster. You keep it on, they'll keep going down, but it'll be slow. Does that make sense?
Would you say 17 years was a bit too much then?
That's a very long time to have dementia, but no, if you take it off, even after 17 years, the decline will go faster.
We're in that now, but I finally woke up to the fact that 17 years is just too long.
It is, especially for caretakers. And when we get to the next part of the dementia, that roller coaster part, you may want it to decline faster and get through that part to the next plateau. And so there's strategies to think about. You don't necessarily want to slow down the behavioral problems. And so here's some of the names. You mentioned the Exelon, which is rivastigmine. There's Aricept. There's Remenil, Rezadoxymanine. All of these work differently, but the research shows they all work about the same, statistic-wise. Everybody has different strategies. What I would do is, at the first sign, I would start a half dose of one of the cholinesterase inhibitors. When I saw them again, if things started to decline again, I'd increase it. The next time I see them, I might add an NMDA inhibitor like Namenda or Memetine's the other name for it. Some doctors just go full blast and start both of them at the same time. But if they have side effects, we want to know which one. These are not no's to these medicines, but they may make asthma worse. If they have GI problems like diarrhea or ulcers, they may make those worse. And rarely, I've seen it a couple of times, they'll slow your heart rate down or even give a bundle branch block, and so your heart rate can go into the 40s or 50s, and they're not miracle drugs, so that might be a reason to stop it. So it can upset your stomach, so you want to start at low doses. The rare side effects that we rarely see is it may disturb your sleep, cause a runny nose, muscle cramps, make it hard for you to hold your ear. So one of the issues too that's very hard on caretakers are the sleep issues. They're very compromising. If they don't sleep, you don't sleep. It's like having a newborn baby. So what we want to know, is it hard for them to fall asleep, or do they fall asleep and it's hard for them to sleep through the night, the maintenance? Are they sleeping during the day so they don't need to start at night? Are they taking caffeine at bedtime or stimulating med after 3 o'clock in the afternoon? And just anyway, as we age, our sleep gets less, we sleep lighter, we wake up more times during the night than a teenager would who needs 15 hours of sleep. Elderly people usually need 6. And so It does get lighter as we go down. We don't go into that deep sleep anymore after our teenage years. We just kind of stay in those first 2 cycles where we wake up a lot. But we still want to stay in bed during the night and not mess up the kitchen. So at first we want to make sure they're stimulated during the day and not sleeping all day. So when you have dementia, you'll get apathy, your concentration goes down, you just kind of want to sit. If you don't stimulate them, they will sleep. TV has trouble keeping them up because if they can't see well or hear well or their memory's not good enough to follow the show, they'll sleep. So we want to reduce the napping. We can do that by keeping them busy, taking them to the store with us, going to lunch with friends, walk-in, or day centers, which we are hoping to get one of those started in the future.
We need another one. We need some.
And that the more social you are, the more active you are, the better you're going to sleep at night.
I don't have trouble with my husband sleeping at night, but we did have him on generic Seroquel, and one night he got up 26 times.
On the Seroquel?
Just right after, you know, constantly. And I quit giving it to him, and he goes to the bathroom once and can find his way.
So that's a very good history. The timing is there. We're gonna have. We're not gonna follow the textbook. If the timing's there, then it's true. I don't care what the textbook says. Yeah, we're all individuals. Textbooks are just on average, and so over-the-counter medicines are usually not recommended. A lot of them have that anticholinergic Benadryl effect, and we don't want that. Melatonin is good, but it doesn't really make people fall asleep. It'll take a couple of hours for that one to work, but it doesn't have any side effects or anything to worry about. If that doesn't work, trazodone is a common one. It's good for sleep maintenance. One thing to look out for, it's very rare, but I've seen it a couple of times in the emergency room, priapism. Priapism is an erection that doesn't go away, and that needs medical treatment. Remeron is one. It's a depression medicine that we use, but a big complaint with that one is they have very vivid dreams that seem very real, and they can't even tell, did I dream it or did it really happen? And they don't like that. They'd rather not sleep. It does increase your appetite, which is a good thing usually. Gabapentin is a seizure medicine that's pretty safe and can help with sleep. Balance may be an issue with that, kind of like the Klonopins and Valiums and things. Ambien is okay, but it's very short acting, so it's good for people that can stay asleep but they cannot fall asleep. You got to give it to them when they're under the covers and in the bed. If you don't, things get weird because it works as soon as you swallow. And you mentioned Seroquel, especially if delusions are keeping them from sleeping. Seroquel is very sedating for most people. It's like you've experienced on the list of possibilities. The next part of our journey is this middle part, the mild to moderate dementia, and this is where we get the behavioral change. And this is probably where most of the interest is going to be, because this gets ugly. This is a quote from Ravens, which is one of the Johns Hopkins pioneers of what we're talking about. Among caregivers of patients with dementia, behavioral problems are the most common cause for institutionalization and nursing home placement, rather than the cognitive or memory problems. We can handle the memory stuff. It's when they start punching and breaking things that we hit our wall usually. So the same thing, we want the history to be very specific. I don't want just a blanket term they get agitated. I want to know, what does agitated mean to you? When does it happen? What time of day? Were they violent before all of this? And this is part of their personality. How long has it been going on? Is it all the time? Is it just at night? Is it just when we're giving them a bath? Or is it just barely happening at all? Are they sleeping well? Are they eating well? Have there been recent medicine changes, like y'all brought up? Or are there recent medical issues? And so you always tackle these, and it has to be in this order. Is it the environment causing the behavior issue, the delirium that we went through? Is it a psychiatric issue? Are they agitated from depression or anxiety? If we rule all these things out, then it's a part of the dementia. Part of our brain that gives us the brakes on things has diminished, and so we have no self-control. And so the environment part, have there been recent changes? Is there a staff member where they're staying that just irritates them? There's somebody here that's taking a picture right now that can say, no, it will not hurt their feelings if you say, back me up on this. There's something about you, you remind them of their mother-in-law, you're making them mad, can we switch? You know, is that going to hurt your feelings? If that gets brought up in a nursing home setting or something like that. Yeah.
Yes, sir.
It doesn't hurt your feelings.
No.
It's just you remind them. So we've worked together, it's fun.
I hope I don't run you here.
So is there a staff member doing it? Is there a certain sitter that does it? Is there a certain family member that rubs them wrong? If so, change that.
I'm probably the one that rubs him.
Yeah, and people act worse at home than they do in public. Is there a behavior problem around caregiving, such as when you give them a bath, they start punching? Could it be pain when you're moving them? They act like you're hurting them because they could have a broken bone that we don't know about. Are they needy or anxious? If so, maybe put them in front of the nurse's station or with you all the time. If they're overstimulated, maybe they do better in their rooms or in some quiet areas. And so this is a math equation. Agitation is stimulation over space. So if you increase the stimulation, you increase the agitation. If you increase the space, you lower the agitation. Or if you decrease the space, like pin them down, strap them to their beds, and put them in a closet like they do sometimes in bad hospitals, that's going to make them even more agitated. So you want to, no offense, it's kind of like if you have an animal, a pet at home, you want to take them to the wide open field and let them run. You know, it's you want more space. You want to rule out the delirium. Did it come on rapidly? Is it waxing and wane, coming and going? Is it from a medicine side effect? You want to rule out the depression. Apathy is one thing, they're flat. Depression, they will tell you that they are depressed. Is it anxiety? Are they restless and irritable? So retrogenesis is going back through childhood in reverse. But babies, if y'all raise babies, they communicate with actions or what we call hissy fits. This happens again when they're going through childhood again, except this time they're 200 pounds and they can bench press 500 and they can tear a door off the hinges and hit you with it. And so we treat it a little differently than we do with our newborn babies. Are they psychotic or is it something else? So a lot of times the most common psychosis will be delusions, and these are just examples. Men, every time you leave the house, you're cheating on them. Women, they can stand in a mansion in front of a full closet and say, I own nothing. Then there's some other ones like Capgras syndrome, is where you're on an identical duplicate. That means you could be the wife of 50 years, but they think that you're somebody in makeup, pretending to be their wife because you're a mirror image of who they remember, or your mole's in a different place than what they remember. And so it's this weird Hollywood kind of thing. And then sometimes they'll see things that you've experienced. Sometimes they'll hear things, but it's usually seeing things. And these can be very dark things. I've seen people interview people, and they have a look of shock on their face, and ask them what they see. And they'll tell me, I see a bunch of babies outside, they don't have eyeballs and their mouths are sewn shut. Yeah, I'd be more scared than you are showing me right now. I mean, it gets dark. Sometimes it'll be friendly things like squirrels playing on the desk. We wouldn't treat that. Or an angel in the room with them. But be careful. That means the demons are right around the corner. You know, one day they're seeing good things, it could get dark from there. Medications that we use to treat this, for the psychotic ones, they may benefit from the treatment if it's very scary. Again, if it's just a couple of bunny rabbits in the fireplace, I wouldn't give a medicine for that. These antipsychotic medicines like Seroquel, like Haldol, Risperdal, those kinds of things. There is a black box warning, and it can be scary to hear that. We all of us have a very small percent chance of dying suddenly. If you take one of these medicines, the black box warning, that chance doubles, so it might go from 0.5% to 1.5%. It doesn't mean they're going to die from it, it just means it's increased. We would prefer to schedule it, kind of like allergy medicines. Scheduling, you can use smaller doses than the as needed ones. Once they're violent, it's very, very hard to stop that, but it's easier to prevent it. So these are the names of some of the medicines that we use. Abilify. Sometimes this can cause restlessness where they can't sit still. Risperdal, if you go above a milligram, you can get some Parkinson's stiffness or that restless feeling. Haldol. Risperdal kind of turns into Haldol once you get over a milligram, so it can cause Parkinson's and restlessness. We don't want to use high doses that cause these things. Seroquel doesn't cause the Parkinson's, but it's very sedating. And then Zyprexa can cause weight gain, which can cause diabetes, but sometimes we want weight gain. We use low doses of these, so hopefully that spares the Parkinson's. If they do get Parkinson's, especially on Seroquel, and we may want to change the diagnosis to one called Lewy body, and they're very, very, very sensitive to these and can get very stiff and Parkinson on very low doses of things that usually don't cause them. And so usually we start at night because they're sedating, but everybody's an individual. If it's sundowning, which means around that dinner time, then maybe we'll give it at 4 o'clock to prevent that. If it's in the morning, maybe we can wait to a low dose of something. But we just kind of go by the individual on that. Some of the disturbances are not due to psychosis. The restlessness. Have you ever been on an airplane and you can't stop moving your legs, or a car trip? That's maddening, in my opinion. It happens to me a lot, and I hate it, hate it, hate it. Antipsychotics will make that worse. I've been called to people's beds, and they keep giving them shot after shot of Haldol, which causes restlessness, and you look at them and they can't sit still, and they're bucking around in the bed that they're tied down to, and you're like, whoa, we're making it worse. We want to give them something like Valium instead. They can be disinhibited, they have no brakes. If they want to touch somebody, they'll touch them. If they want to yell at somebody, they will. Temper tantrums. So you want to be very specific with your doctor and be as specific as you can. We want to treat these with a rifle with a scope on it, not just blast them with something that puts them to sleep forever. So we want to be as specific as we can to get through these bumps. Yes.
What is your opinion on an afternoon dose of trazodone? I've seen that a lot.
Yeah, if it's low enough and doesn't cause them to sleep, that can settle things down. Yeah, can kind of smooth out some of the ripples. And yeah, so that's what we're doing, is we're using the side effects of some of these medicines to help with what is the exact symptom that we're trying to target there.
I got a related question to that.
Yes, sir.
Clear a while ago, we talking about keeping the house or this environment in the daytime, keep the lights on, make the windows up so you know it's daylight. Reverse at night, keep everything dark. What about daytime naps? Can you recommend avoiding all daytime naps? Because I have noticed that as my wife gets tired, she gets more confused, more irritable, but when she's rested and alert, then she's in much better mood.
No, naps are fine. You just don't want them sleeping all day long, to where sometimes people are still going to work and they get home from work and their other is still in the bed. And so if they're sleeping all day, they're not going to want to sleep at night. But naps are fine. Just try to maybe make sure they're not an all-day nap, just enough to get
30 minutes to an hour and a half, early afternoon.
Yeah, or even longer. It's again.
The longer she's asleep, the easier it is to handle.
And we talk about babies. We're talking about babies a lot, and like I said, this is going through baby in reverse. And so, when you have a baby, you want them to take 1 or 2 naps during the day, or they get very, very cranky. And so, that's fine. I nap during the day, and so it's just you don't want to sleep all day because then I sleep. But yes, a nap would be very helpful.
And related to that, I'm also noticing that as the sun starts going down in the evenings, and it doesn't matter what central or daylight savings we're on, when the sun starts going down, she starts getting tired.
Right.
And she's asking to go to bed. Should I comply?
Well, does that mean she's going to wake up at 3 o'clock in the morning?
Could be.
Yeah. That would be, but if she stays asleep, I
But
would jump all
she
over
seems to be
that.
able to go back to sleep. But she is a light sleeper, always has been a light sleeper. So I don't know how to figure that, 'cause
Well, I had 2 children. One didn't ever want to go to sleep, even if the house was full. I liked them sleeping, so I could take care of, clean the house, do my laundry, get everything done at night while they're asleep, and not have to work around them. And so you can take that as an advantage of having some me time if they want to go to bed.
and as a caregiver, I enjoy naps.
Right.
So
Yeah.
if I don't get a nap,
No, take one with her.
yeah.
Yeah, and so find the pattern. Like I said, the textbooks, they just give us ideas, but you know your wife better than anybody. If she does well with 2 30-minute naps or 1 hour-and-a-half nap, go for it and take a nap with her. When you have 1 kid, you can nap with them, 2 on, 2 off. When you have 2 kids, not so much, and you'll lose your mind. But if they're real restless, the other word for that is akathisia. One of the medicines we use for that is a blood pressure medicine called propranolol. The side effect of that is it will lower your heart rate, your blood pressure. You don't want them to fall if they stand up too fast, so we want to watch the blood pressure if we're using that one. Clonazepam is one of those Valium type medicines. If you use too much of it, it can be sedating and cause balancing issues, so you just want to use a little bit of it. It's not good for your memory. Gabapentin can help with restlessness. Remeron can help with restlessness, but it doesn't work as well as these others, but it can work for that. That wanting to walk all the time and where they're just pacing around the house, just going, that's a very uncomfortable symptom to have. The other non-psychotic would be very irritable and agitated where they have no fuse. Sometimes we use another seizure medicine for that, Depakote. We want to look for low platelets and tremor on that one. If it just turns them into a mummy, we want to check their ammonia for that. Buspar can help with agitation. Antidepressants can help. If those 3 don't work, then sometimes we'll go to antipsychotic, but you don't really want to start there because those have the most side effects. And the other ones are very, very safe compared to those. But if they're psychotic, we want to use antipsychotic. So some of the other ones are hypersexuality. If they're doing that, you want to change the environment to avoid some of that. If that doesn't work, they may need treatment. So what we'll do is we'll start with the SSRI antidepressant medicines. Those can sometimes buffer that urge. If that doesn't work all the way down the line, the end point would be using Depo-Provera injection every week. That has a very weird stigma to it. There's an example of that. Somebody was in a nursing home with dementia and they were being sexual with everybody there, even the staff. The nursing home said, either let us do this injection or you're going to have to take them home. This is bad for the other clients. They did not want to take this injection because it seemed very disrespectful. 10 miles down the road, the person tried to rape their grandkid in the back seat, so they turned around and they said, go for it. Another one I had was a principal that had been 4 generations at a school in a small city. Everybody loved him, until he got dementia and started being hypersexual, and it ruined his 80 years reputation. So we want to make sure that that's not happening. Fecal smearing is disgusting. Feces, bowels, they want to, like a child, rub it on the walls and stuff, especially at night. You want to give them a sleeping medicine so they don't do that, or there's clothes that they can't really get to that zip in the back, so they can't keep undressing. Then we have repetitive behaviors or bruxisms, where they grind their teeth over and over again. Different medicines like Newspark and sometimes some. If you can tolerate it, tolerate it. If you need to treat it, we can treat medicines. So most of them are treatable. Those that are not may lead to hospitalization, so they don't lose the placement where they are or hurt you at home. The difficult behaviors will constantly change as the dementia gets worse. As you get through that slow part, the behaviors will go away, and we can stop some of the treatments that we started to get through that part. They turn from a actor to a spectator. Notice once you get to that severe part, they just want to sit in the chair and watch the action going on in the background. So this last part of the journey is the severe part. It plateaus again. They're not very functional. Their memory is very bad. They have trouble communicating at this part. And they're not acting up, but they have other problems that are hard on caretakers, like diaper changes, feeding and bathing and things like that. So this is the severe stage. It's another plateau. Behaviors usually go away. But we don't want to wean the antidepressants because we don't want them to be miserably sad during this part, not be able to communicate that. Some may choose to do hospice and palliative care at this point. This is made hopefully by the client before they get to this stage. The client being the person, their wishes make it easier for the caretakers. They wanted this, I'm not making this decision. During this time, these hospice care people will usually use morphine, they'll use Haldol, and they'll use this Valium kind of medicine called midazolam. Those are the three big ones that they use. They want death with dignity. So you can choose to be at home, you can choose to be in a facility if you don't want to die on your own. They make you as comfortable as possible by managing all your distress and pain. Holistic, which means they want to help the whole body be comfortable and the whole family be comfortable. And this is the summary of what we've talked about. We want to identify the problem. We want to use a rifle, not a shotgun. Be very specific that we're targeting. We want to quantify it. Is it happening 4 times a day? Is it happening once a month? We want to get rid of the things that could be causing it. The daughter-in-law that drives them crazy and has forever. Don't let them come by anymore. We want to select the appropriate agent, medicine we're going to use, and we want to use one at a time. We don't want to add more than one at a time because then we lose track of what happened with side effects. One thing I forgot to put on this is appetite. There are some medicines that can help with appetite if you're not eating. Remeron is one of those, Zyprexa. A lot of doctors prescribe one called Megastraw or Megace. It's good, but they eat sweets. The other ones, they eat protein and everything else. Or marijuana gives you the munchies, and you will eat when you are on marijuana, and that's a good thing for dementia. Sleeping and eating and being calm is a very good thing. So that wraps it up for me, and now we have a few minutes
I often have trouble with him eating. I mean, he's very thin as it is, and when he does eat, it takes him an hour.
Right.
You know, no matter what it is, it seems to take longer. And he, of course, he always chewed slow, and he was always the last one eating. But still, I don't feel like he's gaining any kind of weight, no matter what I give him to eat.
And that brings up a good point. If people are starving to death, we want to feed them like they're our babies. We're not growing anymore. And so we don't need as much food as we used to. It doesn't matter what they're eating. If he'll eat M&Ms, put a jar of M&Ms in front of him. It's just calories that we're looking for. But if he's not hungry, we'll just keep track of his weight. If it's not changing, we're in good shape. Sometimes feeding just adds more feces for this age group. But if they need to eat, if they're getting dehydrated, or starving, or losing a lot of the chemistry that we need, then there are some medicines that can help stimulate their appetite. But anything, it doesn't have to be a healthy diet anymore. But save that for the 40-year-olds and 30-year-olds. Any other questions?
The doctor changed my husband from Aracel 10 milligrams to 20 after he had been tested him, and he went from 19 to 24. He was doing much better over 6 months. But he said, go ahead and change him to double the Aracel.
Okay.
Do you think that's smart?
Yeah, I mean, you want to max it out. If he's tolerating it okay. Sometimes people wait until the score starts dropping a little bit, so they don't use up all their ammunition in the first part. But it'll slow that decline, and sometimes it'll keep people out of institutions because they don't have as many of these other annoying non-memory symptoms. But yeah, and if the decline starts over again, stopping that medicine, it'll be this decline. If you stop it, it'll be this decline, and so it'll decline faster without that medicine. Another thing would be adding on Namenda to it, and that can sometimes be good for the mild to moderate forms of dementia.
It just seemed like he was doing better, so I didn't want to chance anything changing.
Everybody has a different style. I'm not saying I'm correct or not, but mine is, if it ain't broke, don't fix it. Yes?
Is there any type of dementia that causes complete loss of balance? Other people have said, well, he has Alzheimer's. Another one said, it looks like to me he's got Parkinson's or Lewy body, the way he shuffles and walks. So he had the MRIs and the CAT scans and everything. He's had a chronic subdural hematoma, but that resolved itself after a couple of years. But the last MRI showed that, is it the cerebellum, very back part, and all the little tiny arteries are covered or whatever. You can't do a stent, it's not big. I'm just trying to figure out why he just has no balance whatsoever, and he's been to PT for a long time.
Yes, the cerebellum does have a lot to do with your balance, and so if that's not getting enough blood, that will affect it. Everybody with every kind of dementia is eventually going to be wheelchair bound. It's if you like, I keep repeating this, but it's just a very good way for us to visualize it. They go backwards through childhood, and so my kids weren't walking until they were 1, and so once you get past that stage, then they're not able to walk anymore. They don't have the coordination in their brain. Lewy body does have a lot of Parkinson's at the very beginning, and that will affect your walking balance because your steps are very short. You can't stop in time. You can't get your feet in front of you in time to save you from falling. And so if that starts happening, sometimes a walker or a cane or a wheelchair is the best treatment.
Are all the dementias going to have the similar symptoms and the similar medicine? Does it really matter which one it is?
They all follow that same pathway. Some are faster than others. You mentioned 17 years. Some are 5 years, The average is 10 years. They all will follow that same mild, moderate, severe thing. But those little minor symptoms are different. Whatever you start with, whichever one of those you have, it'll probably be the main one throughout the course. So everybody's different in those ways, which symptoms are louder than the others. But yeah, the decline is usually very similar with everybody.
From the Aricept, how long do those good benefits last? He's been so much better since he was, but when he tried the Namenda, that made him worse.
Okay, well that would be the reason to stop that one. The Aricept would be one. Usually it can put them on a flat plane. Usually, I'm not saying with everybody, for 1 or 2 years before the decline starts again, but it'll be a slower decline. And if it doesn't help the memory, it could help with some of these other things, like are they able to talk well, or pay attention better, or something like that. Yes, sir.
From diagnosis to death, you say the average is 10 years?
Yes, sir.
Doesn't depend on your age when you get it?
It does.
It does.
If you're in your 80s or
He's
90s,
in
when you
her
get it,
60s,
it's going to
and it
go
was
faster.
19.
If you're in your
60 was
60s,
2012, I'm sorry, 2015, when she was April 2015 officially diagnosed, and we're, what, 9 years now?
yes, so if you get it early, it depends. If you get it very early, the early onset, which is before 65.
She was early onset, that's what I was told, early onset.
Okay, early onset usually goes faster, and it usually has more behavior problems and more hallucinations along with it. But in your case, that does not seem to be true. There's somebody we know well whose husband had it for 20 years, and so there are those fringes. But most people, it's an average of 10 to 12, 13 years.
Is dementia hereditary?
We don't know the answer to that, how hereditary it is. We know that if you have a family history of it, your risk of getting it is higher. People that have no family history of it whatsoever usually have a lower risk. There is a genetic kind, APO4, I think is it? It's one of the rare ones. It's like 5% of Alzheimer's have that genetic part to it. Those are hereditary. But the way it runs through families, the normal kind of Alzheimer's is it's spotty. It's in the family tree all over the place, but it doesn't necessarily have a 50% chance of getting it like some of those other hereditary things.
That was good.
We do not yet, and this is a frustrating thing for doctors, is that we do not yet have a very clear understanding of dementia or Alzheimer's.
Does the PET scan show Alzheimer's? Because they had my husband do the CT and the MRI and everything, but they also did a PET scan.
That may be a little over my head. When I was working, I didn't order any of those, but they may have come up with a chemical that they're looking for that the PET scan may show.
Because they called me and said, yes, it's Alzheimer's. And said he was in mild to moderate. He was in that phase.
Well, the way I was taught is if you look at a series of PET scans, you can see shrinking along the way. But one is like getting one memory test. You don't know what their brain looked like before that. So everybody in the room could go get a CT scan now, so we would have something to compare it to later if you want to do that. Not everybody likes to